Well, I think, vascular surgeons have a vested interest in patients with aneurysms and with the treatment and the outcomes for those patients. And the earlier we're able to detect these patients, the earlier we can treat these aneurysms while they're less complex, the better the outcomes for the patients. And so I think that's a very good reason for us to be involved in these programs, to make sure that these patients are being identified, being followed, and being referred at the right times, to be able to, for us to take care of these patients and kind of achieve the best possible outcome for them. Yeah, so I think that vascular surgeons should really be involved in every step of the way, from the programs for the initial surveillance studies to the long-term kind of follow-up plan for these patients. And the reason is that the societal guidelines are constantly changing regarding what we should be doing, at what size of aneurysm we should undergo, that patient should undergo intervention, and that those guidelines aren't always followed closely by other specialties, but these are the other specialties are really the ones that see these patients first. Primary care doctors that order the surveillance studies, ER doctors, and also primary care doctors that order studies for other reasons that incidentally find these aneurysms. And so they're not always aware of these are the size criteria for repair. This is how frequent surveillance studies should be done at these different aneurysm sizes. And so our involvement in kind of designing the guidelines for when surveillance studies should be ordered and how frequently they should be ordered and when referrals should be done, vascular surgeons should be kind of involved in that process and keep close communication with these providers that are really seeing patients on the forefront. So I think that vascular surgeons should be involved in that kind of the education of primary care doctors and emergency room doctors and kind of other providers that really are seeing these patients initially, in terms of this is when you should be ordering a study, this is what you should do with the result of that study. A lot of times surveillance can be performed kind of routinely by a primary care provider or by a patient's family practice doctor. But these patients should be, there should be continued surveillance, and these patients should be referred at the right times. And so I think that education and that design of that surveillance protocol, vascular surgeons should really be involved in. So I think getting these patients, identifying these patients that have lost to follow-up has been really beneficial to being able to kind of grow our clinical practice, of course, but then also allowing us to take care of these patients in kind of a more elective, less emergent fashion. And so I think from our perspective, it's been nice to be able to bring these patients back into the vascular fold and really give them the care they need. I think it's also been eye-opening for us to see what are the reasons these patients are lost to follow-up. Is it the patient? Is it the provider? Is it social? Is it cultural? Economic? What are the reasons these patients get lost? And it's actually, it's a little bit of everything. And so it's been really kind of eye-opening for us because, I don't think we're always aware of why patients don't get the care they need. And so from the perspective of us as vascular providers, it's been helpful so that we can really start thinking about how we can really target these problem areas and make sure that patients aren't lost to follow-up for things that are within our control. So I think we're learning that there are a lot of reasons patients are lost to follow-up. And a lot of times we think it's because the providers forget to order studies, or because the patients don't want to have this surveyed, or don't understand the aneurysms are important problems. But sometimes it's for completely other reasons that we would have never thought of. And so I think it's really helping us begin to see that there's all these areas for improvement within aneurysm surveillance. And unlike a lot of other healthcare screenings like mammography or colon cancer screening, those are very protocoled, and primary care doctors, family practice doctors, everyone kind of knows like this is what you're supposed to do at whatever age, once a year, once every 3 years, once every 5 years. Like they have these protocols in place, and we really don't have that for aneurysms here at UC Davis. And that's something that we're realizing really we need to work on. And so our hope is that now that this surveillance program has helped us identify some of the problem areas that we can start designing some interventions in terms of education and outreach and developing protocols to hopefully fix this. I think it's really helped us build some good connections with some of the primary care doctors in the area, as well as some of the kind of family practice providers that are really seeing these patients. I think we're realizing that patients really trust their primary care doctors and really trust their family practice doctors to give them the right advice. And we've found that with some of these patients that we've reached out to, they say, hey, well, I'm going to go talk to my family practice doctor or my internal medicine doctor about this a little bit more. And so they really want the primary care doctors to be the ones that tell them you need this screen or you don't. And so I think us realizing that and recognizing how important the role is for these patients' primary care doctors, we've really started to kind of design programs to start reaching out to the groups within our network to really build that relationship so that we can have this kind of collaborative approach to taking care of aneurysm patients. I think that that's what's been really nice for us, because I think for us sometimes in vascular surgery we feel like we're a little bit in a silo, we're in a surgery silo, and patients come when they need surgery, and then we do surgery and they kind of eventually are released back to primary care. And so I think this has been eye-opening for us and helpful for us to kind of have this launching pad to start building those relationships. I think it's been interesting to me to see kind of the reasons that patients are lost to follow-up. A lot of times I think our assumption is that providers just don't know what's going on, but there are a lot of patients who also just are like, I don't want to follow this, and I don't, or I'm not interested in undergoing additional studies, and it's been kind of interesting to me, and I think we haven't fully fleshed out why that is, whether it's that there's not enough patient education on what aneurysms are, is there kind of a fear of finding out more about aneurysms? Is there a fear of surgery? I think there's a lot more to kind of flesh out there, but I always found that very interesting, because the patients that we do see, right, the ones that come to vascular surgery, obviously there's a selection bias. The ones that come to vascular surgery are like, we've looked up all the operations. Like I've heard my parents, my mom had an aneurysm repair, my friend had an EVAR, and so they all come very prepared for the idea of surgery. And so there's obviously this group of patients out there who don't want surgery or not interested in surgery. And I think trying to figure out kind of what is the reason for that, and figure out how we can help those patients. And sometimes the decision is to not undergo further surveillance or never undergo surgery, even if the aneurysm ruptures, and that's okay. But I think to figure out kind of where the barriers are for them in pursuing kind of further vascular surgery intervention, I think is a very interesting area to kind of explore further. I think that's been what's been really surprising.